should be more than 160 over 100. BP more than equal to 160 over 110. So this BP criteria, and any other criteria you can say?
Proteinuria.
Yes, proteinuria, then severe headache. Remember this one, severe headache, epigastric pain, vomiting, okay. Then blurring of vision, So, any other thing? Severe pedal edema and exaggerated deep tendon reflex, that is ankle clonus. Those are considered as severe preeclampsia. Okay, the BP criteria more than 160 over 110, and remember the severe headache, vomiting, and epigastric pain, blurring of vision, sometimes sudden blindness, and the exaggerated deep and neurological sign like the ankle clonus and severe edema. Those are considered to be having severe hypertension, severe preeclampsia. So sign and symptoms, and then next, what are the investigation done in preeclampsia? You know it, mainly the CBC, then the LFT, KFT, coagulation profile, and always do not forget to say the peripheral smear for knowing the evidence of hemolysis, LDH, urine, routine microscopic, and protein. These are the investigation generally we do for the severe preeclampsia. Okay. Then what is HELLP syndrome? That is another thing you may be asked in the examination. HELLP is hypertension, H for hypertension, then HEL for enzyme, then low platelet count. So this is HELLP syndrome. So this is also considered as severe preeclampsia. Okay. So what criteria I told you include in them HELLP, if there is HELLP syndrome, or there is convulsion, that is eclampsia, or there is any evidence of the organ damage like the kidney failure or acute renal failure, liver failure, you can consider them as the severe preeclampsia. Okay. They may ask you how you evaluate. Then you should say all the investigation that is for the mother, and say something for the baby like the ultrasound to know the fetal well-being, gestational age, like Doppler sometimes we do. Then they will ask you mainly the treatment part. Treatment means treatment are categorized as per mild, moderate, and severe. That may be asked how you will treat. They will say a case scenario of mild hypertension or preeclampsia, and they'll ask you how to manage. So many of you may get questions from the preeclampsia. That is one of the very core things. So tell me how you manage the mild to moderate preeclampsia or PIH. In mild to moderate, what we do is we give some antihypertension. So again, the starting of the preeclampsia or PIH is important, whether it is early onset preeclampsia or it is late onset preeclampsia. Early onset means if the preeclampsia starts prior to 34 weeks, that is called early onset preeclampsia, and they tend to be very severe than the late onset preeclampsia. And late onset preeclampsia, they start having high BP up beyond the 34 week of gestation. In that case, it is easier to manage them because the pregnancy is advanced and we can treat them by delivering the baby if the gestational age is more. You know, the only treatment of preeclampsia, this question may be asked you, what is the only treatment of preeclampsia? The answer is the delivery of the baby. Okay. So the cause of preeclampsia is the fetus itself. So the removal of the baby is a treatment to preeclampsia and PIH. So sometimes they may be asked you what is the pathophysiology, means how come the baby is responsible for PIH and this thing. So it is the answer is there is invasion. You know, the trophoblastic invasion that takes place in 2 phases during pregnancy. One in the first trimester, maybe 8 to 11 weeks, and second one is the second trimester, maybe this is 16 to 20 weeks. So there are the two types timing of invasion, and if there is inadequate trophoblastic invasion, then the spiral artery cannot be converted into a low resistance circuit. Okay, the muscular, what the trophoblastic invasion, they invade the muscle layer in the blood vessel. So the blood vessel, they are more distant, no more there, and the pressure is less. So that high resistance circulation is converted to a low resistance circulation during pregnancy, and that helps the fetus getting blood, and that is the main thing what happens during pregnancy. But in preeclampsia, this invasion does not take place. This trophoblastic invasion. That is why this paralactate they are more resistant and the BP becomes higher. So that is the mechanism how does the baby responsible for PIH. Okay. And treatment you can categorize into two regimens in PIH and preeclampsia. And mild to moderate means the blood pressure is less than 150 over 160 over 110. Okay, so that is the highest limit. Beyond that, we take severe preeclampsia or PIH. So both the things, the mild, moderate, severe classification is same. In mild to moderate, if the treatment depends on the gestational age and the severity of hypertension. If gestational age is less, you can give them antihypertensive. What is the antihypertensive of choice? That is labetalol. Okay. In both pregnancy-induced hypertension and preeclampsia, and labetalol you can give. They may not ask you the dose, but they'll ask you what are the antihypertensive. Those, if you remember them well and good, 100 milligram TID we can give, and if it doesn't work, then you can give the calcium channel blocker like nifedipine. Two drug you remember used as antihypertensive during pregnancy. Okay, labetalol and the calcium channel blocker, and also alpha methyl dopa. Initially, alpha methyl dopa used to be the drug of choice to treat PIH and PE, but nowadays it is labetalol. Okay, these three drugs you remember as antihypertensive. This will use, and then next, if the blood pressure is under control, then you can wait up till 37. It is advisable to wait up till 37 weeks if possible. If BP is controlled and no problem is there, you plan to deliver by 37 weeks. P, there is no, pregnancy should not be continued beyond 37 weeks. You should plan to deliver at 37. If protein is negative and no sign of severe P is there, you can wait up till 39 weeks, but your plan should be delivery beyond 37 weeks, not before that. But sometimes there may be some problem where we need to deliver them early, particularly in severe preeclampsia, or if there is HELLP syndrome, or if there is an evidence of organ damage or any fetal problem is there, then we deliver early. In that case, you should consider giving steroid. Why we give steroid? That is for long maturation, right? And always remember this prophylactic medicine when severe the blood pressure is over 160, over 110, and if there is sign and symptom of severe preeclampsia, what I said, the headache, blurring, vomiting, epigastric pain, or clonus, or convulsion. Convulsion, it is treatment like eclampsia, but in severe pain, other than convulsion, we give prophylactic magnesium sulfate to prevent the occurrence of the eclampsia. Eclampsia can be prevented, but you cannot prevent pre-eclampsia. Usually, it's not preventable. But we give aspirin to prevent the severity of pre-eclampsia. That we will discuss in the prevention early. So remember the treatment. Always remember the antihypertensive. I told you 3 drugs to remember: alpha methyl dopa, labetalol, and the calcium channel blocker, that is nifedipine. Then remember about steroid. If you are planning delivery earlier, then steroid for the fetal long maturity. Then remember about the prophylactic Maxol. If the BP is in the severe PIH range and the evidence of severe preeclampsia, then you should include prophylactic Maxol. And always remember the dosage of prophylactic Maxol, magnesium sulfate, and the treatment is same, almost the same as what we use in eclampsia. Can anybody say what is the dosage schedule? Maxol. Remember, you are asked about the magnesium sulfate dose. Remember the Richard regimen, that is 4 milligram IV, and then IV starts, and then 5 milligram IM in each buttock. That is the loading dose. Means 14 milligram we give loading dose, and then for every 4 hourly till 24 hours, or till the onset of the last seizure or the last delivery. So that you have to remember. The Richard regimen and the Juice-Pan regimen, that is the IV regimen. IV regimen also sometimes they ask you the dosage. That is the 4 is the you give, that is 2 milligram per kg is the loading dose, and then 1 IV per hour, that is the maintenance dose till 24 hours. So that is the IV regime. They sometimes ask you what is the difference, advantage and disadvantage of IV and prepared regime. So the advantage of IV regime is that there is no risk of injection abscess. It is comfortable, but in prepared regime, as multiple injection is needed, risk of the injection abscess and pain is there. And disadvantage of IV regime, sometimes you need to know the magnesium levels, monitoring is needed. And again, another important question is, if the question is on back regime, how do you monitor? That is a very important question. Even you can get a case scenario like PIH, severe PIH, eclampsia, and they may ask you this thing. So if you answer magnesium sulfate, the next question would be how you will monitor the magnesium sulfate. If somebody is getting it, then how you will monitor. And we monitor the magnesium sulfate always by clinical monitoring. Clinical monitoring means, what is that? Prophylaxis or treatment, the dosage is same. Okay. I have already discussed, and the monitoring of the mag salt means you have to see what is the toxicity of magnesium sulfate. Can anybody answer? You are listening or you are just everybody listening?
No, ma'am, we are
or
listening.
not listening?
Yes, ma'am, we are listening.
So magnesium
Yes, ma'am.
sulfate toxicity, mainly you remember few toxicity like this. First, if the magnesium sulfate level increases, then first thing to go is the reflex. The deep tendon reflex will be absent first. Okay. So that's the reason why we monitor magnesium sulfate by respiratory rate. Then urine output, count the respiratory rate, see the urine output. And third one is DTR, deep tendon reflex. So the first, if magnesium level increases, say 4 to 7 milliequivalent per liter is the therapeutic range. This is also asked to undergraduate. And if the level goes beyond that, there is toxicity. And first sign of toxicity is the absence of this deep tendon reflex. If deep tendon reflex is not there, you think of toxicity. That means the first neurological side effect, that is muscle hypotonia and loss of deep tendon reflex. Second one is it may affect the kidney. If magnesium sulfate itself does not cause any renal problem, but if the patient is having renal failure because of the severe preeclampsia and urine output is less, then what will happen? The magnesium will not be excreted by the urine and the level built up in the body and give rise to toxicity. So that is the reason we look for the urine output, and the output should be at least 30 ml per hour. Okay, 30 ml per hour. That is the safe thing. If output is less than 30 ml per hour, we stop giving that dose. Till the output returns to 30 ml per hour, we'll just be omitting that sort of magnesium sulfate. Say patient has taken the loading dose and 2 intramuscular you have given, and by third dose when it is given you found the urine output is less than 30 ml per hour. So in that case you have to stop that sort of that, and then next you evaluate. If the urine output improves, you can give the next dose, and if it doesn't, then you don't. So that is there. So as Maxalt is excreted in the urine, we see the urine output. And respiratory rate, if the respiratory rate should be, what is the normal one? If magnesium sulfate causes respiratory depression. If the respiratory rate is low, when our normal respiratory rate is how much? If it is lower than that, then you think of magnesium sulfate causing respiratory depression. The other side effect of magnesium toxicity, CNS depression, then the cardiac side effect like cardiac irregularity, arrhythmia, this can cause. So this thing you will remember, magnesium sulfate toxicity, and at what range it is effective therapeutically 4 to 7, and if level is more than 12, it causes the respiratory depression and CNS depression. So that they may ask you at what level it causes, what side effects. So that is important. You go through it. The next is I told you about the mild, moderate, and then severe treatment. So antihypertensive, we talk about steroid, we talk about the magnesium sulfate prophylaxis in case of severe preeclampsia. Okay. And this is all about the blood pressure part. Then the fetal part, okay, so if you find the gestational age is less than 34 weeks and you want to continue till term, if BP is controlled, the patient is settled, you can continue. If that is not there, BP is not controlled and patient is continue to get the sign of severe preeclampsia or develops convulsion or organ damage or any evidence of fetal distress, then you may have to deliver them early. You should realize that delivery is the only treatment of preeclampsia, so you have to take the baby out. Okay. And again, they may ask you convulsion. What is eclampsia definition? You remember, and how you treat the eclampsia. You remember the intravenous regime and the intramuscular Pritchard and Jusman. These two regimes enough for you to remember. Okay. So, thoroughly read this area and you hypertension. Then next time I ask you how you can prevent the preeclampsia, and you should be able to utter the name of aspirin, because now we give aspirin in the dose of it. They may ask you the dosage. Nowadays we give 150 milligram, and that can be started once the patient viability is established. And whom we give the prophylaxis myself, those who are having history of past history of preeclampsia or eclampsia or HELLP syndrome, okay, those with SLE, those who have chronic hypertension, there is a chance they may get superimposed preeclampsia and eclampsia during pregnancy. So these are the category who should receive the prophylactic vaccine. And nowadays we also screen. How you screen preeclampsia? Nowadays we screen by the different clinical based risk factor, like the presence of diabetes, hypothyroid, past history of preeclampsia, past history of eclampsia, then SLE or antiphospholipid syndrome, past history of kidney disease, past history of the chronic hypertension. These are the categories whom you should be able to find out in the history. So find out the risk factor in the history, that is one. Second one, we do a Doppler in the first trimester, second trimester, that is the PI of value, and from that we can be able to predict who may develop this thing. And they may not ask you this. You can say the history-based risk factor and Doppler study in the first trimester and second trimester can be used to predict it, and the prevention is that is 150 milligrams daily, and that can be given up to 34 weeks. And how does the aspirin help? It reduces the severity of preeclampsia and delays the starting of preeclampsia. Those who had the early onset preeclampsia in their previous pregnancy, if you give them aspirin, the severity of preeclampsia may be reduced and the starting may be delayed. So that is the reason why we give them the prophylactic aspirin. So this is all about the preeclampsia. What is the next? You can tell me your topic. Okay, the view is blocked. Let me check what you said. Next is your
And diabetes in pregnancy.
diabetes. You don't get so frequently, don't get questions so frequently. Okay. So they may ask you how you screen for gestational diabetes. So you know it by this glucose GCT, glucose challenge test, and nowadays what is used? We give 75 gram estimated blood sugar after 2 hours, 75 gram glucose, and after GCT, that is glucose challenge test, and do the blood sugar after 2 hours. Yes, after 2 hours, if the value is 140 or more than equal to 140, we consider them as screen positive. So that is one step, diagnostic and the screening test for gestational diabetes. So this is the test used nowadays. Okay. And if you find somebody having blood sugar more than 140, then you can give them MND, that is nutritional therapy. Give them diabetic diet and repeat the DCT after 4 weeks. Okay. To see if the level is more than 140 or not. If somebody is still continuing having it, then we do the fasting and postprandial blood sugar and advise either treatment is gestational diabetes, maybe it's diet alone, if blood sugar is maintained also with diet, then give them diabetic diet. and somebody not maintaining with it, then it can give them insulin and the oral hypoglycemic agent. So that oral hypoglycemic agent can be given during pregnancy. That is metformin we can give. Okay. And this thing they may ask you how you treat it, and sometimes they may ask you what are the complications of gestational diabetes. You all know what is it? Mainly maternal complication, fetal complication. So fetal complication is, you don't forget to say, that is macrosomia, and then more of polyhydramnios, macrosomia. Then what else? Fetal distress, then sometimes fetal growth retardation may be there, and then all infection, UTI, VTI, other things they may get, and unexplained fetal death may be there in gestational diabetes. So few complications, you can 4 or 5 complications of gestational diabetes during pregnancy. Then intrapartum. Intrapartum, what can happen if big baby is there? Then risk of instrumental delivery, cesarean section is more likely. Instrumental delivery is more likely. Then shoulder dystocia, that is a typical complication of gestational diabetes with babies macrosomic, and you are delivering vaginally. So that is there. You should not be forgetting these things. Those are important. Mainly intrapartum, and then and antepartum complication of diabetes, and following for baby macrosomic, then all hypoglycemia, hypocalcemia, this thing can develop in the baby. Okay, so this should be able. What are the complications of diabetes? That thing they may ask you what is gestational diabetes. Anybody having the blood sugar higher? That is during pregnancy, who is not diabetic prior to pregnancy. Okay, pre-gestational diabetes is different, and those who develop diabetes during pregnancy, we say them gestational diabetes. Okay, so they may be asked these questions. And Rh negative, again, they may ask you what are the tests you do in pregnancy, and from the blood group they may go to Rh negative. So somebody having negative pregnancy, Rh negative blood group, and what will happen if mother is Rh negative and baby is Rh positive? They may ask you this question. So if his mother is Rh negative, how will you investigate them? If Rh negative, then the next question is what about the husband? Husband is Rh positive or negative. If husband is Rh negative, no need for the sophisticated investigation to be done for the mother, right? If husband is Rh positive, then only there is a chance that the baby may be positive. So in that case, problem happens. What happens is there is some amount of feto-maternal transfusion during pregnancy and after pregnancy, after delivery, during pregnancy, and in the early postpartum. Immediately after the third stage. So that's the timing where feto-maternal transfusion can happen. So they may ask you what are the conditions where this transfusion happen. You remember early pregnancy bleeding. If it is there, then there is a chance. Then any trauma during pregnancy, any antepartum hemorrhage, or some ectopic pregnancy. Okay, so those are the events where the feto or any intervention program like the amniocentesis or corneal coronary villus biopsy, feto-maternal transfusion can happen. And during labor and during cesarean section, if manual removal of placenta is done, then more risk of feto-maternal transfusion. They may ask you this question: what are the conditions where there is risk of increased feto-maternal transfusion? Okay, so this you should be able to answer. Like during pregnancy, delivery and cesarean section, manual removal of placenta. Then third stage of labor, there is chance of feto-maternal transfusion. And once the baby and placenta is out, maybe short time following that. So that is the reason why we don't give methadone in the third active management of third stage of labor just after delivery of the antral shoulder. In Rh negative pregnancy, we usually give the this thing in after delivery of the placenta. That can be given, not immediately after delivery of the antral shoulder, because that may cause the feto-maternal transfusion. So this is asked, and when there is a risk of feto-maternal transfusion, you always admit anti-D. So this thing then ask how much anti-D you will give. So usually we give 300 microgram. That is the standard dose of Roculon or Rh negative antibody. If you find any event that the chance of fetal-maternal transfusion is likely. And second one is the RS prophylaxis, what we say during pregnancy. What is RS prophylaxis during pregnancy means during pregnancy we do the ICT. ICT is indirect Coombs test. If it is negative, we give them RS prophylaxis, and the prophylaxis includes 300 microgram of Roquelaure anti-D antibody. Okay. So, is there is risk of fetal-maternal transfusion during pregnancy. That is the basis why we give them a prophylaxis during pregnancy, and that is ICT should be done around 24-26 week of pregnancy, and you may offer them a RS anti-D injection at 32 weeks, 28 to 32 weeks of pregnancy. One injection is enough, and after delivery, then another important question: when you should give anti-D injection? Usually within 72 hours of the delivery. So after delivery, you can give within 72 hours of the delivery. That works best. So timing of anti-D injection that is important. But they may ask you, if somebody fails to take the anti-D, then how long maximum you can give? So up till 10 days we may give. Timing of anti-D, that is important. You should remember this anti-D. Okay. So within 72 hours, but can be given up to 10 days. So these are the questions you should prepare. Sometimes they ask you how you monitor the pregnancy, and monitoring of pregnancy in RH negative is by doing serial ultrasound. We monitor the growth, we monitor the liker, and sometimes what happens in RH negative, if fetal-maternal transfusion is there, that development of the anti-D antibody in mother, and that comes from mother to the baby and cause hemolysis in the baby. So if there is hemolytic disease in the baby or not, you should evaluate them. And how you evaluate? By doing the ultrasound, we evaluate the anemia in the baby. And how that is done? By using MCL, peak systolic velocity of middle cerebral artery. Okay, so this is very important. So if we evaluate if there is fetal anemia is developing or not. Many a time we don't do the invasive test, means take fetal blood by cord blood sampling and estimating the hemoglobin. That we don't do nowadays. Non-invasive way of monitoring fetal anemia in RH negative pregnancy, peak systolic velocity of middle cerebral artery. So PSC of MCL is important in monitoring RH negative pregnancy. If you find the PSC higher, then there is risk of fetal anemia. If PSC is higher than risk of fetal anemia. In that case, you do the invasive monitoring. Like invasive monitoring means do a chordocentesis, take out the blood, estimate the hemoglobin. If it is less and the pregnancy duration is less, you may consider the fetal transfusion, intrauterine fetal transfusion. And if the baby is mature enough, you can deliver them, and then after delivery you can give them blood transfusion. Okay. If the fetal anemia or evidence of hydrops, it is there or not there, that can be known by simply doing the peak systolic velocity of middle cerebral artery. Okay. So you are getting, so RH negative you may ask case scenario basis and sometime in the oral. And normal labor is very, very important. Okay, normal labor and fetus in uterus, dummy pelvis. I think you are well versed with all these things. Yes or no? Yes or no? Or you want me to say something? In normal labor, always remember the definition of normal labor. Okay. Remember the definition, remember the stages of labor, remember the mechanism of labor, like the flexion, engagement, okay, internal rotation, restitution, extension. This mechanism are very important. They may ask you how to manage the second stage of labor, how you will conduct the delivery, how you will take care of the baby. And labor you read thoroughly. Labor analgesia, they is hardly asked. What labor analgesia we use, just shortly you remember, we may give them analgesic, simple analgesic like the tramadol or pacitidine or tramadol we give. Sometimes the protaverine we give. And the epidural analgesia they may be asking you. So I don't think they'll ask you much about labor analgesia. Okay, infertility again they'll ask you definition of infertility, then what are the male factor, what are the female factor, okay, and in how many percentage of case both are responsible, okay. So they will ask you then causes of the tubal factor, what are the causes and how you evaluate the tubal factor. So what is the answer? How you evaluate? One or two tests you suggest? Everywhere one or two tests. Then ovulation induction, okay. Drugs in ovulation induction that may be asked. And you will not be having theory class, they may ask you orally. So infertility, even case also you may get. In case of infertility, they may ask you how you evaluate the female factor. So evaluation of female infertility, you can get a group them into these things. General investigation, then investigation targeted towards the ovulation is happening or not, and the third one is tubal factor. So that investigation you remember, okay. So and treatment, infertility treatment, ovulation induction is of that importance. They may ask you to name the ovulation inducing drug and all, okay. So these are there. PCOS, you may get a case of PCOS, clinical case scenario they may give you, and they may ask you how you will evaluate and the investigation you do for PCOS. And the Rotterdam criteria of PCOS. Can anybody answer what is Rotterdam criteria? That is for diagnosis of polycystic ovarian syndrome. Rotterdam criteria. याद है कि नहीं है?
नहीं मैम.
नहीं है. Rotterdam criteria is there is 3 criteria. Out of that, if 2 is present, we say the patient is having polycystic ovary. So what is the first criteria? The first criteria is clinical or biochemical evidence of an ovulation. Okay. Very simply I am saying clinical evidence of an ovulation means what? That may be having irregular cycle or amenorrhea, okay, or infertility. And biochemical evidence means if you are doing a ovulation test and she is not ovulating, that is clinical or biochemical, or the raised hormone, this thing, LH, FSH high, these are clinical or biochemical. Second thing, clinical and biochemical evidence of the hyperandrogenism. Okay. Hyperandrogenism, clinical evidence is hirsutism, acne, change in the voice, okay, obesity, hyperandrogenism. Biochemical means it's increasing the level of the testosterone or the androstenedione, these things. So usually from clinical scenario only you can be diagnosing the PCOS. And third criteria is finding a polycystic ovary in the ultrasound. And what is a polycystic ovary? The polycystic ovary is a one which is enlarged and have multiple follicles, which is more than 12 the count and the volume is more than 10. That we say is a polycystic ovary in the ultrasound. So first one is clinical or biochemical evidence of hyperandrogenism, clinical or biochemical evidence of the anovulation, and third one is finding a polycystic ovary in the ultrasound. If 2 out of 3 is present, we say them to have polycystic ovary. And the management is as per the symptom. If somebody having irregular cycle, it make them regular by giving hormone progesterone or the oral contraceptive pills. Okay. And somebody having an ovulation, then you treat them with ovulation inducing enzyme. Somebody willing for pregnancy, you treat them with ovulation inducing this thing. Or if that one is not working, injectable ovulation induction, or sometimes laparoscopic ovarian drilling, what we say, that is the LOD, laparoscopic ovarian drilling. Sometimes this is helpful, laparoscopic ovarian drilling, LOD. Okay, and then if patient is obese, the key treatment of PCOS is weight regulation, means they should maintain their weight. Okay, so that is a very, very important step, and maintaining weight also helps them to ovulate and to conceive. So many good advantage of PCOS. advantage of complication may be avoided by reducing or maintaining the weight only. And they may ask you what is the long-term complication of polycystic ovarian syndrome. Okay, long-term complication is hypertension, diabetes, some endometrial hyperplasia, sometimes endometrial. Very rarely they will develop endometrial cancer. This thing they will ask you. Okay, long-term complication and treatment. Whatever symptoms she is having, you treat them accordingly. Like treatment of irregular cycle, treatment of infertility, treatment of if they want contraceptive, you can give them OC pill. Okay, sometimes androgenic medication like the cyproterol acetate. For somebody having acne, hirsutism, that is hyperandrogenic symptom, you give them cyproterol acetate. This is the anti-androgenic medication we give. Cyproterol acetate. So any contraceptive containing the cyproterol acetate is the drug of choice in polycystic ovarian syndrome. If somebody is using for contraception as well as want to treat the hyperandrogenic symptom, then any contraceptive that contains the cyproterol acetate will be the drug of choice to reduce the hyperandrogenic symptom like acne, hirsutism, or the other thing. Okay. And this one usually many things are available, Crimson 35, Cerazette, not Cerazette, Crimson 35, and you can give that contains pill containing cyproterol acetate is this thing, Dan 35, Crimson 35, these are the category of pill which contains cyproterol acetate. And if you want to prescribe a contraceptive pill to a PCOS, maybe the pill containing cyproterol acetate will be the most choiceable medication, that is Crimson 35, Dan 35, like that. They may not ask you the brand name, but they may ask you anti-androgen that is used in PCOS, that is cyproterol acetate. And other things like hirsutism, hair in the upper lip, lower lip, you can give this medication at the same time waxing saving, this category they may use. So all symptoms are based on whatever symptom they come to you. Okay, that is the treatment. And the second important thing is you have to stay them to weight reduction and the lifestyle modification. That is the key thing in polycystic ovary. And they may ask you how do they present to you, then what are the long-term complications. They may ask you this thing. And endometriosis. In endometriosis, they'll ask you what are the signs, symptoms, what is endometriosis, where they can be found, how you will evaluate. So, what is the gold standard of evaluation and treatment of endometriosis? That is laparoscopy, okay? And chocolate cyst, they may ask you how you will treat chocolate cyst. Mainly, it's treated laparoscopy, okay? Laparoscopic cystectomy. And laparoscopy is the gold standard for treating endometriosis, okay? Diagnostic laparoscopy. And wherever the endometriosis site are found, that may be fulgurated or cauterized, chocolate cyst may be removed, okay? And theory, this thing they may not ask you the endometrium. There are a lot of theory. And again, what are the non-surgical treatment of endometriosis? They may ask you. They may answer the progesterone, then your dihydrogesterone, all kind of progesterone, oral contraceptive, medroxyprogesterone. Okay, so these are the treatment for medical treatment. And surgical treatment, they may ask you where you need surgery. They may ask you if chocolate cyst is there, how you are going to treat. Then infertility in endometriosis. Okay, usually the tubes are not commonly blocked in endometriosis, but severe endometriosis are best managed by vitro fertilization. Okay, in my case, you may treat the endometriosis, ask them to conceive, and you know the pregnancy helps in relief of the endometriosis. If the patient gets pregnancy, the endometriosis they get reduced, and if pregnancy is there, the severity is also reduced. So if they conceive on their own, it is okay. Otherwise, in endometriosis, treat the endometriosis, ask them to conceive, or give sometimes the surgical treatment, medical treatment, all the hormone I told you, then DNRH agonist, you can give that injection, leupride, depot preparation can be given for the relief of endometriosis. And whenever you prescribe the injectable one like Glimepiride for 3.75 or we give GnRH analog, in that case you ask the patient not to conceive for 3 months. After that they can conceive. While giving this injection, that means two types. The concept is that if hormone is given, that is the pseudo pregnancy treatment, and the GnRH analog you are giving, that is pseudo menopause treatment, means you are creating a menopausal state by giving the injectable GnRH. So that helps in reducing the endometrial severity is reduced, and after that 3 months you tell them to follow some contraceptive, and then they can start planning for the conception. That thing is there. Okay. So if you compare both the treatment, then sometimes surgical treatment is good because they can immediately try for the conception. But in injectable DNRS, if they take, then the contraceptive has to be followed for 3 months, and then they may plan. So the outcome is almost similar in both the cases, and here the intervention, surgical intervention is there only injection. So that thing very rarely they may ask you. Okay. Chocolate cyst you prepare in the endometriosis, then sign symptom of endometriosis, how do they present? Okay, then dysmenorrhea, how do they present to you? And dysmenorrhea is very typical in endometriosis. They ask you how does the dysmenorrhea is different in endometriosis than other, they may ask you. In endometriosis, dysmenorrhea, it starts prior to the menstruation. Then during the cycle they get the pain, and even after the cycle bleeding has been stopped, then also they may get pain for some time. So this is the typical complaint of dysmenorrhea in endometriosis. Okay, they come with the presentation of menorrhagic cycle, pain. Okay, they may come with a ovarian cyst. So how do they present clinically? This is a question may be asked. Then they may ask you the treatment, the pseudo pregnancy treatment, pseudo menopause treatment. Okay, chocolate cyst, you can get a clinical case scenario also you may get from endometriosis. Even infertility, PCOS, this thing you can get case scenario, and hypertension, every type, that is very much included in the core area. So you prepare very thoroughly hypertension in pregnancy. Okay. Then fetus in utero, then normal labor, these things you prepare. And fetus in utero means you should learn all the lie, presentation, position, all definition you remember, and then you remember the definition of the different area. Different area means the face, what is the definition of face, definition of vertex. Okay, all the definition. So what is vertex? Vertex, face, brow. So vertex is the area that is bounded by what? Anteriorly what, posteriorly what, and laterally what? Anteriorly what suture is there? Coronal suture. Posteriorly there is lambdoid suture. You remember or you do not? And
Yes, ma'am.
both sides, the line passing through the parietal eminence. That is the boundary of vertex. Then they may ask you what is the boundary of brow. Brow, the boundary is from the coronal suture to the nose, then the supraorbital ridge. Okay, this of the nose, and this affects which one? What you say, the root of the nose and the supraorbital ridge. So that one is brow, and below that thing, all are face. Face means from the where the boundary of brow, lower boundary of brow means the root of the nose and supraorbital ridge till the mentum, junction of the chin with the neck. So that is the boundary of face. This one even theoretically definition you get, but this time you will not be getting theory. They may ask you what is face, what is brow, like that. They may ask you. And all the denominator, line, presentation, position, and always remember the LMP and EDT. LMP and how you calculate EDT. Okay, how you calculate gestational age. These are very fundamental. Let me ask you this question. And different presentation means all presentation. What is transverse line, face presentation, brow presentation, face presentation. Okay, so of that you prepare the occipito posterior. Posterior, this one is important. They may ask you how you manage occipito posterior presentation. Okay, normal labor you learn how it is done. Okay, now what is the mechanism of labor in occipito-posterior presentation of labor? So in occipito-posterior, three things can happen. The posterior may rotate anteriorly and deliver normally. Sometimes they may incomplete rotation. So incomplete rotation, it should be transverse arrest. In that case, they need instrumental delivery or cesarean section, and sometimes non-rotation give rise to occipito-posterior direct lateral arrest. Okay, so oblique arrest, non-rotation, malrotation. And if they rotate posteriorly, that is, they may deliver normally as face to pelvis delivery. So face to pelvis delivery, how does it happen? They may ask you face to pelvis. Always remember which one comes first, delivery. And in the dummy pelvis, they may ask you to sew. I don't know, they will give you dummy pelvis to sew or what? Or not? What they have to.
Maybe, ma'am, we don't know.
So I also don't know because you don't be having dummy pelvis at home, no? So I don't think they will ask you to say, or they may show you in the dummy pelvis some presentation and ask you what is it, the normal left occipital anterior or right occipital posterior or transverse line breathe. They may show and they may ask you. I don't think so. Always remember this definition. You remember and all. Definition of all the presentation, vertex, breech, brow, face presentation, denominator, this thing. And sometimes, the management is very easy. Normal delivery, and occipito-posterior, the management can be cesarean section, instrumental or normal delivery or face-to-pelvis delivery, this thing, and rest face, in which face presentation you can deliver normally. Always remember in mento anterior we can deliver normally, but all mento posterior should have cesarean delivery. Then another thing they may ask you in the face presentation. Okay, in all diameter you remember. Okay, in completely flexed vertex, what is the diameter? In completely flexed, then what is the largest diameter? What is that? That is the mento vertical. That is the brow presentation. And this one they may ask you what is the diameter of presentation in face and in vertex. In the vertex, the diameter presenting is what? So completely flexed vertex, the submento. What is that? Suboccipito or occipito-bregmatic? What is that? Suboccipito-bregmatic. So in the vertex, the smallest diameter in a well-flexed vertex, the diameter that presents is suboccipito-bregmatic. Right? Am I right?
Suboccipito-bregmatic.
So what is the well-extended face? What is the diameter of presentation? That is submento-bregmatic. And both the diameters measure how much? It is 9.4 centimeter. Okay. So they'll ask you 9.4 in your book. In that side maybe 9.5. It is written 9.5. Okay. So they'll ask you how does that differ? Which one delivery is easier in vertex or in face? Both the diameters are same, but where do you find the delivery to be very easy? Is it vertex or face? Anybody can answer?
Vertex.
Very good. So why? What is the reason behind why it is easier to deliver a vertex head than a face? So try answering. You may commit mistake here. I am not taking your examination. This may be asked to you. So in vertex what happens? There is sutures, right? So there can be molding. So molding reduces the diameter of vertex by 4 millimeter. But molding, is it possible in face? No. Yes, there is no molding. All joints are fixed. So there is no molding in face, but molding can happen in vertex presentation. That is one reason. Second one is vertex is a well fit to the lower uterine segment and cervical opening. Face being irregular, it doesn't make a well fit. So dilatation is easier and faster in vertex, but the dilatation is not so faster in face presentation. And vertex makes a regular bag of membrane, but for face makes a elongated bag of membrane. So which may rupture early, and that may create problem. Then second one is tumification. What is the edema on face is known as? Edema on fetal face is known as tumification. So that they may ask you what is it, tumification, and because of the face is tumified, its size increase. So there is hindrance to delivery. So these are the two reasons why the delivery in vertex is easier than the delivery in face. The vertex being allows molding, reduces the diameter of up to 4 millimeter. Second thing, it makes it well fit to the lower implant segment. And a regular BOM makes the dilatation of the cervix easier and progressible, faster. Whereas face tends to tumify. So the tumified face makes a larger diameter of presentation, and as it doesn't make a regular fit at the lower implant segment, there is elongated bag of membrane is formed and it tends to rupture early. So that is the reason the delivery in the face presentation is not very favorable than the vertex presentation. Only the molding and tumification, if these two things you will be able to answer, then you get your full score, right? Then the next one is fetal syndrome. Okay. So all the definition you remember, all the diameter of engagement, and particularly you remember what is the diameter in well-placed head, what is the diameter in extended vertex, what is the largest diameter, what is the diameter of presentation in face, brow, like that they may ask you. Okay. So that table is there in your duster, you go through it and you remember it from well-flexed to completely extended head. The diameters are there and you can remember the size. Then in the pelvis part, they may ask you the boundary of inlet, the fetal skull and maternal pelvis. They may ask you the boundary. Remember all the bone and joint. Okay, if you fail to answer anything, they may ask you what bone constitutes the pelvis and what are the joints present in the pelvis. Okay, these are the questions asked before you tend to fail in the examination. Then next they may ask you what is the boundary of inlet. Okay, remember the boundary of inlet, bone in the pelvis, then joint in the pelvis. These are the lifeline question. Okay, if you don't know this, you will fail. And then next you remember the anterior diameter of all the diameter of the inlet. You remember they frequently ask you related to dummy pelvis, and the anterior conjugate, particularly the anatomical conjugate, the obstetric conjugate, and the diagonal conjugate are very frequently asked. Then interspinal diameter, then importance of the ischial spine, they may ask you. Okay, in the maternal pelvis, like here the internal rotation takes place. So this is the landmark internal, where the internal loss and external loss, anatomical loss, then what are the other rotation takes place at this level, and we say station related to the ischial spine. The station is considered 0 when the head is at the level of ischial spine. So that they may ask you this thing. Okay. And fetal skull, you remember the fontanelle, importance of fontanelle and the diameter. So that's it. And in maternal pelvis, mainly you do the diameter of inlet, bone and joint only name. And then you do the obstetric, what is obstetric outlet, what is anatomical outlet, diameter of the outlet you do. And the diameters, you should remember all the diameter of the inlet and the diameter of the interspinous diameter. This thing you can remember in the pelvis. Okay. And mechanism of labor, they may ask you, but I don't know, they will tell you to show how does a normal delivery takes place, because you will not be having the dummy pelvis. So they may not ask this thing. Then what is next? Different presentation of fetal. I have told you all the presentation you remember. Okay. Like bridge, vertex, and transverse line, you remember, and everywhere how you diagnose, how do they present clinically. Okay, so how you diagnose a bridge presentation for abdominal, what should be the finding, for vaginal, what should be the finding, how you differentiate a bridge presentation from a face presentation by vaginal examination. This thing they may ask you. Okay. Can anybody answer how we can differentiate face and breech?
The alveolar margins can be felt vaginally in face presentation.
In face presentation, always remember, even in breech, we will find a opening. Okay, in face that will be mouth, and breech that will be the anus. Okay, and you find a triangle of bone. Okay, in breech you will find both the sacral ischial tuberosity and then the symphysis part. Ischial tuberosity and sacrum, tip of the sacrum, 3 bones. You can even in face you will find 2 malar eminence and the chin. So there is sometime in advanced labor there is a confusion between face and the breech presentation. So what you should answer in the breech presentation, you may feel the opening anus and your finger may be stained with the meconium. Okay, but in the face presentation, if your finger gets into a cavity and the suckling starts, means that is a face presentation. Okay, so that is there, and the 3 bony eminence, that the ischial tuberosity and the tip of sacrum and ischial tuberosity, that will make a single line, but in face they tend to make a triangle, 2 malar eminence and chin. Okay, so in advanced labor, the breech and face is difficult to differentiate. Only you will be able to differentiate if your finger is meconium stained or if you are feeling the genitalia of the baby. Okay, then that is a breech presentation. If your finger goes into a cavity and you feel the alveolar ridges and the suckling of the baby you can feel, then you can confidently say that that is a face presentation. There will be no meconium even if your finger gets into a cavity. Okay, that is the only difference you should say in the examination, and that is important. Face and breech. Sometimes they'll ask you for abdominal examination finding in breech presentation. So you should be able to describe you will feel the breech in the pelvic grip and hand in the fundal grip in breech presentation. Okay. Transverse lie also on one side, you will feel the hand and breech on the other side. So it is easy. I think you'll be able to answer in different presentation. And all presentation, normal labor, you know how it is done. And parthogram, sometime you remember. So what is the aim of parthogram? That is to monitor the progress of the labor. And ideally, parthogram should be used to monitor the first stage of the labor. And when it should start, when the cervix is 4 centimeter dilated, it should start. And we plot the dilatation, descent, uterine contraction, fetal heart rate all in a graph. That is called parthogram. In a graphical record of the progress of labor is called a parthogram. In the parthogram, sometimes they may ask you the X1 line, alert line. To a good student, they may ask you. So what is the meaning of that line? The alert line means if the progress of labor is not progressing satisfactorily, then there is a point where the dilatation descent is not appropriate and your distress of labor touching the alert line means you should remain alert. Something is going wrong with the labor progress. In that case, you re-evaluate what is the fetal and maternal position. If you find, and there, all correctable defects can be corrected when the parthogram graph touches the alert line. And what are the correctable defects during labor? If the uterus is not contracting well, then you can add a oxytocin drip to get a active contraction, adequate contraction. And second one, if the mother is dehydrated, then you may give them fluid to correct the dehydration. So the defect that you can correct is the correction of the dehydration, and if uterine contraction is not adequate, you can add on a oxytocin drip to bring adequate contraction. And despite correcting these things, if the labor is still not progressing well, then what you think of? So you may think of there may be some other thing. Okay, hypotonia is not a factor, dehydration is not a factor, then you think of some element of cephalopelvic disproportion, CPD or presentation malposition of the baby may be there. And in that case, the patient, if the parthogram line starts not progressing well, it touches the X1 line, you take action. Either say if it is occipito-posterior and due to non-rotation labor is not progressing, you may carry out the instrumental delivery, that is the ventouse or forceps delivery. Okay, and if it is means not amenable to instrumental delivery, then you can consider delivering by cesarean section. If it is there in the institute, if the facility for instrumental delivery or cesarean delivery is not there, then it is always advisable when the partogram becomes abnormal, it touches the alert line or the next line, you refer the early referral to a higher center where the operative delivery can be performed. Sometimes this thing is asked, okay. And presentation हो गया, then fetal growth restriction means what are the condition where height will be more than the fundus more than the period of amenorrhea, or height of the uterus less than the period of amenorrhea. These causes they may ask to. And fetal growth restriction, how can you say when the growth of the baby is not appropriate, then you say fetal growth restriction means when you examine a patient, first you calculate the period of gestation, okay, and the height of the uterus should match with your period of gestation. Since if somebody calculation of POG is 24 weeks, means our fundal height should match 24 weeks. If it is less than the 24 weeks, then we may think that either it is fetal growth restriction or that may be wrong. So two things you can say. So you cannot say that baby is growth restricted at one antenatal visit. So serial visit or serial measurement of the fundal height or serial measurement of the ultrasound weight can only say that baby is growth retarded or not. A single measurement cannot say you anything. Okay. Fetal growth restriction, sometimes case scenario they may give a baby, pregnant lady says 30 weeks gestational age comes to you, when you examine her, height of uterus is only 24 weeks. So in that case, the fetal growth restriction may be there, and second thing, her LMP may be wrong, she may be remembering her gestational age wrongly, and that is the reason that wrong EDD may be there. So they may ask you how will differentiate a growth restriction and a wrong EDD. So when EDD is more confirmatory, okay, how you calculate the EDD? We calculate always from the LMP, and that is if you calculate EDD from LMP, on that day only 4% delivery occurs, okay. Whatever EDD we calculated basis on the menstrual date, out of the 100, only 4% deliver exactly on that EDD date. Rest they deliver 1 week before or 1 week after, okay. And the EDD, menstrual EDD is not very reliable. Always the ultrasound EDD is very reliable, and particularly ultrasound in the first trimester. Okay, first trimester means within 12 weeks, whatever ultrasound they have, the calculation of EDD within weeks means somebody is in the ultrasound, it is 10 weeks, that means that is 10 weeks plus minus 7 days. In the second trimester, the calculation error is plus minus 2 weeks. In the third trimester ultrasound, the error is plus minus 3 weeks. So always when calculating EDD, we should check for the first ultrasound, the earliest, the best. And from that only 1 week, few days error is there. So that is more reliable, and we consider dating scan from the first trimester ultrasound only. And from that scan you calculate. And if your patient's fundal height matches to that, that means she is not having IUDR. If it does not, then you may think of, and at single visit you cannot say this baby is not growing. Once you suspect, say a 30-week pregnancy comes to you and you find her fundal height to be 26 weeks, then you suspect IUDR. At that time we do a growth scan. Growth scan means that scan should be repeated after 3 weeks, and we measure the fetal growth and growth velocity. And if after 3 weeks also the baby growth is not increasing satisfactorily, then the growth velocity is not matching as per the gestational age, then we can say them growth restriction, okay. And growth restricted baby, usually you should try to find out in the history what are the causes why there is growth restriction. And the most important causes of growth restriction is, most common causes, you should be able to tell about the preeclampsia, eclampsia, hypertensive disorder, okay, any connective tissue disease or the SLE, antiphospholipid syndrome. These are the most, and viral infection like the TORCH infection, any TORCH means Toxoplasma rubella, this thing, viral So can be there. So you should be able to find out in the history like what are the risk factor of the, if somebody is having risk factor of growth retardation and you find on examination the fundal height is less, then you advise them for the serial ultrasound for monitoring the growth and growth velocity, and usually growth velocity is monitored from the first time after 3 weeks, at 3 week interval we do. If the growth is not satisfactory, we send them growth restriction, and usually there is no treatment for growth restriction. Any time we give them the lycopene, calcium, vitamin, amino acid, and many nutritional supplement. But if some intrinsic reason is there for the baby's growth restriction, so the best way is to deliver them when the intrauterine environment is very hostile. So that is there, and we deliver them. They may grow better when they are out from the uterine environment. Okay, in IUDN, sometimes the early onset, again this is also like the preeclampsia, there is early onset growth restriction. That means if there is growth restriction below 32 weeks, and if growth restriction diagnosed after 32 weeks, and the prognosis is better when the growth restriction is started in the late restriction, means after 30 weeks, because you can wait and you can deliver late, and early growth restricted, the prognosis is not so good. In that case, we do serial ultrasound and we do the Doppler to find out the fetal condition, and whenever we suspect the baby is in jeopardy or then we decide for the timing of delivery. Here they may ask you how you decide for the timing of delivery. So we do the serial scan for fetal growth and the Doppler for the fetal well-being. Okay, and when you suspect the baby the Doppler is not normal, then we decide for the delivery. And usually we give steroid if the baby is less than 36 weeks. Okay, 2 doses, give steroid and deliver early if there is some evidence of fetal distress. If everything is fine, then we may plan to deliver after 37 weeks, or late onset fetal growth restriction should be delivered late, means beyond 37 weeks. Always our aim is to deliver the baby after term. We should not be in a hurry to deliver them before term. Okay, so that is the concept, and always remember this concept. If the gestational age is the main determinant of the baby's prognosis. Okay, the more the gestational age, the outcome, fetal outcome is better. Less the gestational age, the fetal outcome is worse. So our aim is to continue the pregnancy as long as it is we can, means that should be safe to the baby as well as to the mother, but we cannot put the baby's life or mother life into risk to continue the pregnancy. So that is the timing which did help us to decide when to deliver. So depending on the mother's condition and baby's condition, we find a suitable time for delivery in fetal growth restriction. If evidence of fetal distress or fetal jeopardy or the ischemia, when there is a blood flow to the brain is less, then that is the timing where we should decide for delivery. Okay. Brain sparing effect. Then I ask you, what is that? Brain sparing effect means when there is evidence of hypoxia in the baby, the intraplacental hypoxia, then what happens? The body tries to give more blood to the brain, and then it cuts down the blood supply to the other part of the body, because brain is the most important organ in the body. That we say redistribution of circulation. Less blood goes to stomach, liver, and all, and more blood goes to brain. That is called brain sparing effect. Okay, and if brain sparing effect is present, that means that the problem is started. Okay. So evidence of how we look for the evidence of intraplacental hypoxia, that we can answer from the Doppler study of the serial Doppler study of the fetus. We know about the blood circulation to the fetus, and whenever you find there is a Doppler abnormality, it is always advisable to deliver the baby. They may not ask you what sort of Doppler abnormality. This is not for an undergraduate. If you are able to say Doppler abnormality, will help us to decide when to deliver. Okay, so that is enough. Then PPRM, you might get a case scenario, and this is important. Then ask undergraduate PPRM. Okay, they may not ask you at fetal growth restriction, but PPRM is the core thing. PPRM, IUFD, your endometriosis, fetus in utero. These are the important chapters. Different presentation of fetus, then your normal labor, then hypertension in pregnancy. These are the key areas. These are the core area of whatever list you have given to me. And PPRM is easy, I think everybody knows it. So many of you might have seen and discussed the case in the ward. Yes or no? You're listening or not listening?
Yes, ma'am, we are listening.
So you have your interest intact? We will continue or?
Ma'am, we can continue.
Okay. In PPRM, so they may ask you how you diagnose. So the diagnosis is by doing a speculum examination. If you see a liquor escaping from the cervix, then your diagnosis is confirmed. Okay, that thing they'll ask. What is PRM? So what is term, preterm, postterm? This definition may be asked in this context. And PROM is the PRM definition is when there is rupture of membrane before the labor occurs. Okay. And PPROM, the preterm pre-labor onset of PPROM, the definition, all definition you remember. PROM is before labor, rupture of membrane before labor. PPROM is preterm pre-labor rupture of the membrane. Means before 37 weeks rupture of membrane happens. Okay, so that is PPROM. The definition is important. Then they will ask how you will diagnosis. Okay. Diagnosis. So by doing an examination, again by doing ultrasound, like less. And very importantly, the history the patient gives you, because of fluid has been leaked, and you ask whether that is soiled the underclothing, soiled the her clothes, and like the amount should be more in PPRM. Okay, so the amount of fluid leak, the color, and this thing can help you diagnosing. Okay, how you diagnose means you start from the history, a history of leaking, a gush of fluid, and amount should be little more. It should be soiling her clothing. Okay, and sometimes the fluid flows through her leg and drop on the floor. So this is the typical history they give. If the history they give, then you next you do a post-speculum examination to see whether fluid is escaping from the cervix or not. If it is there, then the diagnosis is done. Then they may ask you, somebody give a case scenario, somebody say 32 weeks, 30 weeks with the PPRM comes to you, how you will be managing. So first you evaluate, do a speculum examination, confirm the leaking, see the color of licer, okay, and see that she is in labor or not in labor. Since she is not in labor, then our aim is to continue the pregnancy till 34 weeks, okay, and we plan for delivery at 34 weeks. Then next they may ask you, if you do conservative management for PPRM, so how you will monitor the pregnancy, then at what are the criteria to deliver them? In PPRM, usually we that is plan to deliver continue the pregnancy till 34 weeks. Okay, unless and until she develops some other criteria that is needed for delivery. So, what are the criteria when you plan to deliver in PPRM? The first one is if they develop the chorioamnionitis. Okay. Second, if they go into labor, or if there is abruption or any other problem with the baby or mother develops, then we plan to deliver them before 34 weeks. Otherwise, our aim is to continue them till 34 weeks. Okay. The next, how you will monitor PPRM. The monitoring is very, very important. So we monitor for what? We monitor for the mother. It will try to find out what are the signs and symptoms of the chorioamnionitis for mother. So we will ask about fever. What are the signs and symptoms of chorioamnionitis? Fever, tachycardia. Okay. Then house smelling, discharge of the liquor. So these are the symptoms. Which one the patient, if she gets fever or get house smelling liquor, they should tell their treating doctor. Okay. And next we monitor every day fetal heart rate, maternal pulse rate, maternal temperature. If high maternal pulse rate or maternal temperature is there, then they may suggest chorioamnionitis. So this clinical history, examination, and some investigation we do, like the total leukocyte count or CRP is raised, leukocyte count is raised, then that points toward chorioamnionitis. If it is there, then we plan to deliver. Okay. And next, if they go into labor, then we deliver them. This is the second criteria when we deliver them early. Okay. Or any fetal distress, evidence of fetal distress or abruption, then we deliver. They will ask. This is the criteria for delivery. And monitor. You monitor for chorioamnionitis, monitor for labor means daily you palpate the abdomen, listen to the fetal heart sound. If there is evidence of uterine contraction are felt, you may say that the patient is in labor. And fetal distress means from fetal heart sound you may find tachycardia or you may do a CTG, find the testing if some abnormal thing is there, you plan to deliver. Then in PPRN, they may ask you what are the investigation you would like to do in this case. So your investigation should include all the routine antenatal investigation and along with that investigation that is needed to exclude chorioamnionitis. Okay. The chorioamnionitis means what are the investigation, that is TLC, okay, CBC case that improves TLC, then your CRP or what else? Extra investigation is that total leukocyte count, CRP, and you do ultrasound, obstetric scan, or Liker and fetal well-being. That thing you do. Okay.
Excuse me, ma'am.
Or CRP is high, then you should plan for delivery. So that is all about PPR. Investigation, you remember. Post-term, I think, you know what is term, preterm definition, you know what are the signs, some complication if pregnancy goes beyond. So are you still interested?
Ma'am, we have another class actually from 1 o'clock. So,
Another day will cover?
ma'am?
So you need to stop, then we'll stop now. Okay.
Yes, ma'am.
Maybe help you, let me know.
Okay, ma'am. Thank you, ma'am.
Thank you, ma'am. Attendance is done. Should I leave the call?